Welcome to the Jewish Orthodox Women Medical Association, or JOMA podcast. I'm your host, Elisa Minkin. I'm a general pediatrician and also proud member of JOMA. And I'm here with another proud JOMA member for at least the second time, Dr. Denise Moses. Hi.
Hi.
Thank you so much for doing this, especially on short notice. I'm going to warn our listeners that you came straight out of work. And if it comes to data, it's going to be on my shoulders. I am surrounded by papers. I'm going to try the best I can to be the data wonk here. So I'm just going to reintroduce you briefly. Dr. Moses, MD, FACOG, is a board certified OBGYN. She received her undergraduate degree at CUNY Brooklyn and a medical degree at SUNY Downstate. She completed her residency at Hofstra North Shore LIJ Health System. She currently works at a private practice located in Queens, New York called Healthcare for All Women. So here we are. Back to COVID again. It's very sad because we did a talk, pandemic pregnancy. I looked at the date. It was end of January 2021. So a full 7 months ago. And at the end, we were like, we're almost there. It's the final stretch. And it wasn't.
Yes.
Wasn't.
Slightly disappointing.
So disappointing. It's a very demoralizing time. I mean, it's kind of like, it reminds me of the Charles Dickens novel, It's the Best of Time, It Was the Worst of Times, because in the way it's the best of times, and that we have vaccines that, despite what you might be hearing from the media, are very effective at doing what they should have been advertised to do, and that's should, which is to significantly decrease severe disease, hospitalization, and death, not just get rid of COVID. This idea that we will get rid of COVID is not happening.
Right. COVID is staying. There's no getting rid of it. It's like the flu. It's going to be around for a very long time. And because it can constantly mutate, the issue is to protect ourselves from getting sick. So the way I talk to my patients is it's not about getting the vaccine or not getting the vaccine. It's about getting the vaccine or getting COVID.
Right. Right. And when you say mutated, we should be careful of not comparing it to the flu, and that the flu really mutates at a much more rapid rate and it actually becomes a different strain. COVID is not mutating at that rate. It has what we call variants of concern. The latest, not the latest, but the one that's sweeping the country is the Delta. And that's what makes it really be a choice of vaccine or COVID at this point.
Exactly.
That any of the other mitigating strategies that you do don't hold a candle to the infectiousness of COVID, which is just insanely infectious.
Yes. Yes,
right?
It's awful. It's awful.
Right. And you can still get COVID even if you have the vaccine, which is another important message to get out. And this would be even more true for people who have underlying conditions.
Right.
I don't have any data on breakthrough infections of COVID during pregnancy.
I think there isn't anything out there as of yet.
Mm-hmm.
Anecdotally, from what I'm seeing recently, a lot of the patients that we have that are getting COVID are actually unvaccinated
Mm-hmm.
during pregnancy. But we are hearing about breakthrough infections in general, not only in pregnant women, but in the general population. And we know that those people that are vaccinated have a less likelihood of ending up in the ICU, of having severe disease, and even death.
Right. And again, it boils down to understanding that the risks to a pregnant woman of COVID are known and very high. And I think the different position that we're in now than we were back in January is, we said they weren't studied in pregnant women, which is quite unfortunate. However, I'm sorry?
That has thankfully changed.
Right. Well, we're using it now. So,
yeah.
We have real world experience, and I know people want to hear data. So I kind of looked up some things. First of all, you have the American College of Obstetrics and Gynecology. I have the Society for Maternal Fetal Medicine, and I had just printed out, this is a little bit of an older version of it, but if you go to the website, Society for Maternal Fetal Medicine, provider considerations for engaging in COVID-19 vaccine counseling with pregnant and lactating patients. I mean, this is really meant for providers to talk to their patients.
Right.
But it was sent to me and I have it. But anybody can look at it.
Right. Everything. the practice advisory that I have is
Mhm.
not something that you need to log in for. Anyone can Google it and look for it.
Right,
So it's really, the information is out there. The right information is out there. The credible sources are out there. Nothing
right,
is being hidden
right.
in terms of what our guidelines are in terms of what to tell patients.
Right. So I want to read what the Society for Maternal Fetal Medicine recommends because it's changed. You know, when we did our talk, we had no data back in January to base recommendations. We knew that COVID was dangerous for pregnant patients, but we didn't have evidence that it was safe for pregnant patients. So we were making a risk benefit decision with tremendous uncertainty. I would say we're still making risk benefit decisions with a lot of uncertainty. It's not like we now have certainty. We're not here to tell people, guess what? Now the COVID vaccine is 100% safe for pregnant women. We're not going to say that.
Correct.
Nothing's 100% safe, first of
Nothing's
all.
100% in this world.
Right. But our knowledge is better, but 7 months later, it's just 7 months later.
Right.
Right. So what they say is the Society for Maternal Fetal Medicine recommends that pregnant, postpartum, and lactating breastfeeding people and those considering pregnancy receive the COVID-19 vaccination. That is so strong compared to the way it was in January, where they said you should have a risk-benefit calculation conversation with your healthcare professional. Big difference, and way big from the World Health Organization saying women shouldn't get it. Everybody should listen to my talk, our talk together. January is called Pandemic Pregnancy. This will probably be called more Pandemic Pregnancy. Should listen to it and stay to the second fake ending, go past the fake ending and go to the real ending, where we go over the World Health Organization communication fiasco, where they first said, we don't recommend it. And again, they said that because there was limited data, and then they ended up changing on that. And it was really just a communication disaster, because sometimes we have to make decisions with really very little information, and we have to figure out what is the less riskier of two options.
Exactly. So yes, the Society for Maternal Fetal Medicine came out very strongly in favor of getting the vaccine prior to pregnancy, during, and after pregnancy.
Right. And I don't believe there's any timing recommendations.
No.
I know we kind of obsessed over this.
Yeah, it could be given anytime during the pregnancy, and anytime with other vaccines. I think just one of the major recommendations that have affected the women in my care is, if they're getting the COVID vaccine, then to not get a mammogram right after, because it can cause some swelling of the lymph nodes.
Right. And again, we are not saying that the vaccine has no side effects or no adverse effects. Of course it does. And one of those is that lymphadenopathy, which can persist for a while. And so, like you said, that should determine when you get your mammogram. You might want to get your mammogram before, if you're due for it, and then get your vaccine.
Right.
So, and speaking of side effects, I'm sorry.
Go ahead.
Yeah. I was going to say that the bleeding, there's a lot of concern about the bleeding. I don't know if you were going to say that.
Yeah, that was one of the things I was going to get to, but yeah, go ahead. So we have seen some cases where women get the COVID vaccine and then have an irregular menstrual cycle in the month coming up after that. So it usually resolves on its own. I actually discussed this at the other webinar I did for the college teachers with Dr. Hellman, maybe in May. And, we had talked about that as well.
Right, and that's up on the JOMA website, jowma.org. It's all up there.
Yes. And it's recorded, and definitely a really good one to watch in terms of help for college teachers, for mikvah attendants, just in terms of the information about the JOMA vaccine as relating to those groups of women.
Right. Do we know why this occurs?
It's probably the inflammation, but it's not totally clear, because we know that the vaccine causes some amount of inflammation and inflammatory response. We think that could be part of it, but we're not totally sure.
Right. Like we think that the way the vaccine works to create an immune response, activates your immune system, can also be in the lining of the uterus. Would that be a good explanation?
That's what people are hypothesizing.
Thinking. So more importantly, how long does it last?
It's really usually just one cycle,
Mhm.
as far as I've seen, and then everything kind of goes back to normal.
It's interesting because I saw that the
Doesn't affect
European,
fertility.
and it doesn't affect fertility. And
Doesn't affect
we
fertility.
have to not forget to talk about that. And again, when it comes to fertility, there is a specific myth about this incision one, about this placental protein, and we discussed that in great length on our podcast, on the webinar, had so many different, so we are not going to duplicate a lot of, what we said already. That would be redundant.
I just want to say it cannot cause infertility. It just can't.
It just can't. It just can't. But you can understand why the bleeding would make people think that it could.
Correct. But one has nothing to do with the other, thankfully.
Right. So what I was going to say is the European Medical Association, I think that's what EMA stands for. I might be getting it wrong what it stands for, but I just happened to see that they came out and said, we want warnings for ringing in the ear, which I've heard isn't actually causally associated with the vaccine. We want that on the vaccine handout because we want people to know that it might be associated. And then there was one or two other things, lymphadenopathy, I think, or whatever, something else. But we do not agree that we should put up menstrual problems on it. Mm-hmm. And they were not saying there's no menstrual irregularities after. I think they were distinguishing between true menstrual problems and temporary irregularities.
Right, right.
And I think, and the other thing to remember about temporary menstrual irregularities is that stress can cause it.
Absolutely. Absolutely. So we always take that into account.
Right. So that's really important. A lot of people think, oh, something happens after, it was because of it. And it might have been a third factor, which is your anxiety about side effects from the vaccine.
I'm happy you said that because I was thinking it too.
Yeah. Yeah. I think that's true for the myocarditis side effect as well. I've heard stories about people going to the hospital with chest pain and being terrified because they had their COVID vaccine. And of course, it wasn't myocarditis. And I think that when we're talking about these side effects, we're being very open and transparent. Back in January, when it first was released, we didn't know this. How do we know that there are these side effects? Because we are monitoring. And we talked about it the last time that we would monitor with the VAERS, which has been so abused, this vaccine adverse events reporting system, abused in the sense that it is a public database that anybody can write into, and you should write into it. You don't have to think, well, I'm not sure. Could it have been from the vaccine? Maybe yes. No, just report it. That's not your job to figure whether there's causally related. But it will be looked into. It's not like everything reported is causally related. And of course, people talk about how somebody said, I became the great brain Hulk after getting my vaccine, and they had to call him and say, are you sure you want to keep this up there? Because anybody can say anything.
Yeah.
But some of it will be real, and that's cause
we have to be serious about this. Like, this is something that actually deserves to be serious about. And it's really good to see that the more people we vaccinate, the more information we get. And so many people have been vaccinated at this point that we're getting a lot more information about what could be a potential side effect, what to look out for, what to expect during that time, and how long these side effects can last.
Right. And I'm going to give a little bit of the data we have, but the data we have is really just from a small percentage of the people who've been vaccinated for the most part. And I think we have to keep in mind that we're giving this all over the world. Right.
Another thing I did want to mention is that most of the adverse effects have occurred within the first 8 weeks of getting the vaccine. And in general, of getting most vaccines, people do not really get side effects from vaccines after 8 weeks, which is 2 months.
Right. Okay. That gives me a segue to do the study here. I'm going to bring it out. Okay. I have short-term reactions among pregnant and lactating individuals in the first wave of the COVID-19 vaccine rollout. So looking at those that 8-week period, this is a very early study. Of course, how could it be out here if it weren't early, right? We're only 8 months out.
Everything's early.
Everything has to be early, and it takes time to do studies and get all the parts to getting a study and getting it published. So in this particular study, and this is very interesting. This is by Elisa, my name. Kachikis, Kachikis, MD, and S et al. It was printed in the JAMA Network Open, meaning anybody can read it. I love that. I love that we are democratizing scientific information. I think it's critical because we're all in this together.
Yes.
Right. So in this particular study, it was a online prospective cohort study of adults, mainly in the US, who were pregnant, lactating, or planning pregnancy at the time of their vaccination. And basically what they looked at as of March 16th, again, this is a very early cohort, and it's a very specific cohort. I think it was healthcare workers, because in the very beginning, you only had older people and healthcare workers getting it.
Yep.
So they had 17,525 individuals. And of this, looking to see for the data here, there were 3 distinct groups: 7,809 who were pregnant, that was almost half; 6,815 who were nursing, and 2,900 who were neither, but planning pregnancy in the near future. And most of them got the Pfizer or Moderna, which in general is true in America.
Yeah, and that's what was available really at the time.
Right. And there's a whole separate issue we'll get to of the J&J, hopefully, of why we don't have as many who had it and why you don't have as much data on it. And that has to be, taken into account if you wanted to get the vaccine, while you were pregnant or breastfeeding and you wanted data. There will be less of something given less to people.
Yes. At
least in the United States. So what they found out from this large prospective cohort study, meaning they were going forward as opposed to a retrospective study, which, this gives us, I think, a higher quality of information than a retrospective when you look backwards. Comparing different groups. And they found out that it was very well tolerated. And again, people can look it up for the details. And again, this was primarily healthcare workers, so that, it was a very specific group. But the bottom line is that the pregnant women were not showing a different set of side effects, and it's a large group.
Correct.
So I thought that was a nice, reassuring study on that particular topic.
Yes. Yes. Very, very good.
I liked that. So back to side effects. I'm sorry.
Yes. Go on.
I just don't want to forget to mention that the J&J has the side effect of the blood clots, and what happened with that is it was picked up through the vaccine adverse, reporting. And I think also our active database is called the Vaccine Safety Database and the VSafe program. And they found there was an increased rate above the baseline, because that's one way if you're seeing more than you usually see, you say, hey, that's a signal. Very rare. And they pulled it from the market. And, that was thought to be very cautious, but meanwhile, COVID was spreading. And not only were people not able to get the vaccine, despite it being a rare effect, it terrified people.
Yeah.
So I don't think we have as much.
A little bit.
I'm sorry?
Scary. It made things a little bit scary.
It made it scary, but this is how we're learning. My daughter hates when I say this over and over, but we're building the plane as we fly it. Right? We can't know rare effects when we do a study on, say, 30,000 people. This was like 1 in a million or 4 in a million. It was like some
People
super
always
rare.
ask me, they're like, there's not anything, there's no studies, there's not enough studies. There are studies. Everything is new because the disease just came out in 2019. It's only 2021 right now. I mean, this is not like, I don't know, Law and Order or something where kind of things move really fast. This is something that takes time, and we're all in it together, and we're all working together to kind of understand better how the disease itself works, how to protect the human race, how to protect each other, and how to prevent the further spread of disease.
Right. And I think it's also hard because once you know about these rare side effects, you may not perceive it as rare.
Right. So even if the Johnson & Johnson, when it had first come out with that side effects, was like, ended up being like a 1 in a million type of thing, or something like that, it's still very stressful to hear that these type of things happen, and you don't want it to be you.
Right, but that's the thing, is that I think people think, and I've heard people say this, I'd rather not do something, because if I give the vaccine and something bad happens, I'll never forgive myself. But if I just get COVID, well, I'll think, okay, I just got COVID. And that's called the omission bias. It's a logical fallacy. We all use shortcuts to try to figure things out.
Yeah.
It
It's very
is.
dangerous. It's
It
very dangerous.
is. And we're here to not to push the vaccine. You know, Joma's been criticized for pushing the vaccine. We do not push a vaccine. We offer information so people can make intelligent risk benefit decisions. You can't do that if you're getting skewed information, whether it's politically biased or because the concept of it leads on the media. It's not interesting. Like millions of people got the vaccine and they got a sore arm, or even they got some swollen lymph nodes, or
It's
even their
kind of
periods
boring.
got wonky. That's not so interesting. It really
Boring.
isn't.
Boring.
Boring, right?
Yeah.
So we're not going to hear all the good things the vaccine does, or all the things it doesn't do.
Right. We have to look at the real numbers. The real numbers are so many people have gotten the vaccine and they are good. They're fine.
Right.
They didn't really have a side effect. Maybe if they had fever, fatigue, sore arm, that's super common. We get that with most vaccines that we get anyway.
Right.
We move on and that's it. And we're protected.
Right. And it doesn't mean that there will be no, right. It doesn't mean that there will be no more severe side effects than that. It just means that those more severe side effects will be rarer. And what you have to do is compare it to what COVID does. Because I still meet people who think, I've never had COVID, I haven't had the vaccine, and they start knocking on wood. They all do that. They knock on wood. Knocking on wood is not going to keep you safe from COVID. And nor will taking vitamins, which is another hot thing that I think a lot of people think, I'll live healthy, I'll take vitamin D, or even I'll take ivermectin, or I'll take hydroxychloroquine. I mean, none of these, right, are proven strategies to avoid getting COVID or getting a more severe form of COVID.
Right. There's only one way.
Well, in a way, there's more than one way. I don't mean to keep being a devil's advocate here, but we are going to be completely honest. And I'm sorry, the vaccine is not perfect, right? And we have Swiss cheese. We've talked about the Swiss cheese, which is different mitigating approaches when there's a hole in one. I don't let you go. Then there's other.
I'm dying.
That doesn't have the holes in it.
It's because it's not just the vaccine, right? Even
Right.
if we get the vaccine, we still have to mask, we still have to hand wash, we still have
Right.
to be smart, we still have to social distance. So that's my one way, but that's kind of what we all really still need to do no matter what.
Right, but when we talk about these things, how many people are going to roll their eyes at this point? How many people? We have been doing this for over 18 months. And I've heard people say we have to learn to live with COVID, and I actually use that for a topic of a talk that I have to re-record, but whatever. But learning to live with COVID doesn't mean at this point to not take it seriously. We hope someday that it will be like a cold or flu, but we're not there yet.
Right.
It's new to us. And not everybody is capable of mounting enough of a response so that it's mild. That's a big problem. So for all the people who say, I didn't have any symptoms and I have antibodies, or I just had a cold, well, that's wonderful for you. But we had, I think, close to 630,000 people just in the United States alone die of COVID. Right? Our ICU beds are full. Children's ICU beds currently are full, which doesn't mean that children on the whole get very sick with COVID. Most of them do not. But when you're talking on a large scale, even a small percentage can overwhelm our healthcare. And once our healthcare is overwhelmed, you can't get good care when you have COVID. You can't get good care if you have something else.
Right.
I saw the saddest thing, a little boy with cancer sitting in his car. He had fever and was under cancer treatment, meaning he was very vulnerable to serious infection. And there was no room in the pediatric ER for him to be evaluated yet because it was full of kids with COVID.
That's horrible.
Yes. So that's why we're not there yet. It's just a cold, just catch it.
It's, there's this number, 99% of kids don't get COVID, or 99% of people recover, and 99% of people don't have severe disease, and 99% of people are fine. But it's not 99%. That's just a number someone threw out at some point, and it's not accurate, and that's not what real life is, and that's not what the hospital is, and that's not what we're actually dealing with. It's really not 99%.
Right. What are you seeing? Because again, I'm a pediatrician, but you're an OB. So what are you seeing?
With my patients with COVID,
Or from
it's,
your colleagues, because I know you talk to a lot of
yeah,
other OBGYNs and
yeah,
I do not as
it's,
much.
so I have OBGYN colleagues and friends that are in different fields of medicine, and they're all over the country, and we all talk. And in general, the COVID situation is bad. Having COVID during pregnancy is bad. There are women that are having miscarriages and what we call stillbirth as their pregnancies progress because of their having COVID, and that leads to lack of oxygen, and lack of oxygen to mom leads to lack of oxygen to the baby, and that can cause miscarriage and stillbirth.
No,
It's really, really unfortunate.
yeah,
And
that
then,
actually these stories were what prompted this particular update.
yeah, yes,
And technically they're anecdotes. I want to be very clear. The plural of anecdote is not data. I don't want to, just do anecdotes. That's why I pulled a bunch of studies. But the problem is, again, we're building the plane as we fly it. Um, it's happening in real life. So we may not have data about what's actually happening, and Delta is changing the picture. I'm not sure if it's more severe or just so much more infectious and you're getting larger numbers. That's where you get to that 99% do fine problem, that even 1% is a lot of people.
it's a
And
lot.
it's not 1% morbidity. It might be overall 1% death rate, on the average, which is first of all much higher for more vulnerable people.
Correct.
But it's also all the disease and disability that it causes, and that's not 1%. It's much more than that. Whether it's long COVID,
Yes,
hospitalization.
yes. We
So
mentioned last time in our podcast that uh, pregnancy is high risk for getting COVID and having severe COVID symptoms. We talked about it last time. It's not changed. It's still severe. It's still dangerous. Um, there are patients in the ICU who are on ventilators, who are pregnant, who are losing their pregnancies, who are having C-sections in the ICU, not even in an operating room. They're not awake for these things. I mean, it's just awful. They don't get to meet their children. And some of these children that are being born are being orphaned. So um, it's 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 horrific. It's horrific what we're talking about. And last time we really tried to keep it just the facts and just what's going on, and not really discuss things that are more difficult. But um, I don't know if you could tell, but it's difficult for me to talk
yeah,
about this because
yeah.
it's upsetting to hear that people that we're taking care of, that our job is to protect these moms and these babies, are getting sick. And there's a possibility that it didn't have to be this way.
Right, because at this point, we have the vaccine, and it was one thing in January when it first came out, and it wasn't studied on pregnant women, and it was so much uncertainty. But the more, you know, good evidence that of safety, not 100%, but a lot of safety we have for pregnant women, and the more we see Delta spread, right, and just get everything that's not nailed down, it's so painful because it is preventable. Have you seen or heard of any pregnant women who were vaccinated in the ICU?
No, no. Um, Everything has been pregnant women who have not been vaccinated. Um, but I will also say that there are pregnant women who have not been vaccinated, got COVID, and then got the vaccine later on in their pregnancy and are doing well.
Right, right. And of course, there's women who get COVID while pregnant who do fine, right? I mean, we're not talking 100%. Let me just read from the Society for Maternal Fetal Medicine just to put it in context. It says here, though the absolute risk for severe morbidity and mortality remains low for dying or for getting very sick for it. In other words, we're not going to say it's 100% at all. It's, most women will do okay while pregnant, even if they have COVID, but there is 3 times the risk for ICU admission, almost 2.5 times the risk for needing ECMO, which is that bypass we talked about the last time. And I've seen that happen. It's horrible. And a 1.7 times increased risk of death due to COVID-19 compared with symptomatic non-pregnant patients. That's really scary. And now we have a vaccine, which we know more about, not 100% certainty, but way more. And again, it's being given all over the world. So even if I can't give you studies that show, 300 million people have been vaccinated, and this is what the number of what happened to them, even if I don't have that, granular data with large numbers to give you, this cannot be happening all over the world. Nobody's hiding anything here. The very fact that we talk so openly about even serious adverse effects, which are rare, shows that we're all being transparent. There's nothing being hidden. It can't be hidden.
Yeah. The hospitals are overwhelmed. The
Right.
ICUs are at capacity, and it's just all over again, something that, we really wish wasn't happening. And it's just very, very difficult to talk about. I mean, we talked about my experience with COVID over a year ago, and we said, I survived it. Does that mean I'm not going to get the vaccine? I still got the vaccine because in the end, I don't want to bring it home, right? Even if you're vaccinated, you could still carry the disease. You could still carry the virus, and we still have to be careful. We have to keep making sure that we mask up, that we wash our hands, because our kids can't get vaccinated as of yet. We just don't want to infect them.
Right. And another hot topic is people who've already had COVID, because, a significant percentage of our population had COVID. And
Yes.
Some of them have been vaccinated and some of them have been not vaccinated. And so they ask a very reasonable question. What's the rate of reinfection versus the rate of breakthrough infection from the vaccine? And that's a reasonable question. It may not be so easy to answer with any degree of certainty for a number of reasons. And I think that's where you have to be really careful about what you see in the media. There've been a bunch of preprints, meaning studies that have not gone through peer review.
Right.
Right. And like I went through one with my dad.
Correct research to look
Yes.
at, right?
Yes, you have to know what you're looking at. And yet the studies, are used in the media to show, okay, natural infection is way better. And so we really have to talk about natural infection. And I think first it's fair to say that when we spoke in January, we did not know as much as we know now about the robustness of natural infection immunity. We do know now that it seems to be in a lot of people, but not all people. And I think people have to be careful about measuring their antibodies to see if they're still immune. And I've said this in the last talk, I'm saying it again, that we do not have an exact correlative protection. There are people who've gotten reinfected with their antibodies still being positive because you need the right antibodies, what are so-called neutralizing antibodies. And as of yet, that is not commercially available. So I did not have COVID, I had the vaccine, and I don't ask why I measured my antibodies. I was told not to, and I promptly ignored it after, as long as it wasn't zero, because I don't know what that number means. Right? Am I so stupid as I'm
going to? Did it to kind of be like curious. I measured mine too, and then they went down. Like,
but what does that mean?
Down to like 7 right before. I'm like, I don't know what that means, but they measured it when I was going into labor, and then I checked it again, at a physical, and I was just like, let me just see where we're up to.
But what does that mean?
Doesn't mean anything. Right.
And our immune system is much more complex. Your immune system is much more complex. You can have memory B cells with waning antibodies. You can have other kinds of immunity, T cells, innate immunity. It's very complicated. And again, you have a lot of uncertainty. And to try to use one number, an antibody test, to give you certainty, it's a false sense of certainty. So when I was calling myself stupid, it's because I talk about this all the time and I know better. And so I promptly said, good, it's not zero. Moved on.
Yeah.
It's not going to change.
My sister-in-law is an infectious disease doctor at Yale, and she said, do not check your antibodies. And I was like, I'm just curious.
Right. So there's a very rational question.
That's
right.
different.
Right. So first of all, I just want to say that when people talk about natural immunity being better, it should be talked about b'diavad, post facto, as opposed to lechatchila, beforehand. That there are people who are saying, I don't want to get the vaccine because I'll get a stronger antibody response if I get the natural disease. If you didn't get it yet, it is risky. It is way riskier than the vaccine. That's the whole point of the vaccine, is to give you a controlled careful, safer, not 100% safe, but safer way to be able to fight COVID than all the problems with the disease. And I've heard people think that, oh, vaccination, it's got stuff in it, it's like dirty. And my perspective is the disease is dirty.
It's a virus.
Yeah.
The definition of germ, no?
Ew.
Did I miss something?
Right? I mean, when they talk about spike proteins from the vaccine, which is a very controlled into your muscle goes away, it's that Snapchat we talked about versus your whole body filling up with spike proteins from the virus that's multiplying all over your body. I mean, to me, it's no question. But again, once you've had it, that's a different question. So when it comes to vaccinating someone who's pregnant, who had COVID already, I think that that's a different risk benefit ratio. I'm not saying not to do it. And again, we are not giving medical advice here.
Right. It's definitely a conversation to have with your doctor.
Yes.
I have this conversation with my patients multiple times a day. We talk about the COVID vaccine all day long because it's something that needs to be addressed. It needs to be talked about. I give out the JOMA website for more information. You know, we kind of need to have this conversation so that people get comfortable talking about it. People get comfortable asking their questions, you know, and people get comfortable realizing that the more people that get the vaccine, the more information we have and the safer it is for everyone.
Right. What are your thoughts on vaccinating people with women with prior COVID who are pregnant? I know that's a very specific subgroup. I'm just curious.
From what we're seeing now, they are still recommending to give the vaccine.
And the reason would be?
There has been some, there was a study that I saw, and I can't remember off the top of my head right now, that showed that the immune response from the vaccine was actually better than the natural immune response.
I think you're talking about the Kentucky study from the CDC. Was it the Kentucky study?
Yeah. So I think that is kind of what they're using. But either way, having more of an immune response or having those antibodies that kind of last longer is kind of what we are looking for in order to protect our patient.
So it's interesting that you say that because I get nervous when I call it propagandize the vaccine. We have to be very careful to not overstate it. I think that was one of the big problems, like I said earlier, when we said, oh, the COVID vaccine is 95% and it's going to prevent spread. And it turns out it didn't prevent somebody from catching it and spreading it to others. We now know that to be true. And again, if they had come out and said from the beginning, here's your expectations, it's going to minimize, not completely eliminate severe disease, hospitalization, and death, and you still can get it, but it'll mitigate it for you. It'll make it less severe. Then we wouldn't be going, oh my God, this doesn't even work, which people are saying.
Right.
It's not true that it doesn't work.
Expectations. We have to know what we're looking for. What are we looking for? So we're looking for something where you're not getting the horrible side effects of COVID. You're not in the ICU. You're not on a ventilator. You're not, having trouble breathing. You're not having organ failure. You're not having all this other stuff that can go along with COVID. And, you're protected from those severe side effects of having the disease with the vaccine. Is the vaccine 100% perfect at preventing people from getting COVID? No. Are they better at preventing people from getting severe disease, from ending up in the ICU, from dying? Yes. And that's the important thing to expect. That's the expectation to have.
Right. And I think, a lot of us are spreading the information from Israel. Israel's been putting out a lot of data. And you have to be really careful because it depends on how you frame the data. So what they should be doing is per 100,000 population, because when you have a highly vaccinated population, if almost everybody's vaccinated, then you can actually have this crazy situation where more people get the disease who are vaccinated than unvaccinated. And that looks to the regular person's eye as it doesn't work. That's called the base rate fallacy. You have to look at how many people are vaccinated. And you also have to look at risk factors. So if you compare a group and one group is very young and very healthy and unvaccinated, they could easily do better than a vaccinated, elderly, or immune compromised population.
Right.
And so that's what's happening in Israel. And they give you the raw numbers. It may look like, oh my gosh, there's all these people in the ICU who were vaccinated and they may be all above 80 years old or whatever. So, anybody who wants to can subscribe to the EMA. It's from Dr. Eliana Aaron, who is a nurse practitioner in Israel and has this program for students, American students who are in Israel. And she has all these WhatsApp groups and I'm on it. And she shares the data. And once they started putting it for 100,000 population, you could see the vast majority per 100,000 population in the ICU, severely ill, hospitalized, or unvaccinated.
And that's the major point.
Right.
Being unvaccinated puts people at risk for all of these other ICU, other side effects of COVID, long COVID, all that stuff. That's the whole message that I think we should try and get out there is what's the difference between getting vaccinated versus getting COVID? And
right.
I'll say it again. What's worse, getting vaccinated versus getting COVID?
No question. It's getting COVID. And back to people who had prior COVID, I think the reason to vaccinate even pregnant women with prior COVID is because that immune response to prior COVID is variable. You can't point to that individual and say, we have a way of knowing that your immunity to COVID is going to last through Delta. And we do have some studies showing, we have some data coming out of Israel showing a significant uptick in reinfections in the general unvaccinated population, which is a smaller percent because a lot of adult Israel is vaccinated, but we're still seeing a significant increase. That's like more than half the reinfections reported in Israel have been reported in the month of August. Like that's a very rapid increase in reinfection, even if it is objectively a small number. I don't want to be manipulative here. It is still considered to be uncommon to be reinfected, although it may be hard to know since most reinfections will be at the mildest end and may be asymptomatic, and people may not be as willing to get tested because they may think, hey, I had it already, which can also be true for people who had vaccines. I'm also hearing people who had vaccines who don't want to be tested, to be fair. But that's really important to keep in mind.
Right. I mean, there's no harm in being tested. There's no harm in knowing.
Right.
Knowledge is power. And I think that, these webinars, these podcasts that you're doing, I mean, it's just really helping people get that knowledge from the correct sources in order to make the decision that's right for them.
Right, and not to be misled. It's so important to go to good sources. There's also Johns Hopkins, Mayo Clinic. I'm afraid to say the CDC, even though there's a lot of good information. I know a lot of people don't trust them and their messaging has been less than ideal. But
I was like, I'm going to keep my mouth shut.
I know. It's also, by the way, I shouldn't say this, but it's like going to the DMV. It's so hard to find things on.
It's the surgeon in me. Sometimes I have to just be quiet. Otherwise, I'll be too blunt.
But ACOG, the ACOG, the Society for Maternal Fetal Medicine, on this topic is excellent. I've given a couple studies. We've been talking about this. I also want to mention that there are comorbidities, right? Yeah. You might want to mention what are the comorbidities of pregnant women that would make them at even higher risk for severe outcomes with COVID.
So women who are pregnant in general are at increased risk of having COVID and having those adverse outcomes. Obesity, diabetes, high blood pressure, I mean, the usual problems really do put people at risk. People who have asthma or other pulmonary disease are at higher risk of adverse outcomes in pregnancy. I mean, these are just to name a few. We know that ACOG does recommend that pregnant individuals be vaccinated against COVID-19. I'm just reading off their website. ACOG recommends that lactating individuals be vaccinated against COVID-19. It says, ACOG strongly recommends that all eligible persons receive a COVID-19 vaccine or vaccine series. What else? Pregnancy testing is not a requirement prior to receiving any emergency use authorized approved COVID-19 vaccine. Claims linking COVID-19 vaccines to infertility are unfounded and have no scientific evidence supporting them. That's it. ACOG recommends vaccination for all eligible people who may consider future pregnancy.
Right, but it always boils down to quote Paul Offit, it's easier to scare people than unscare people. And I did a talk with Dr. Jonathan Howard in August of 2020 before the vaccines came out. And we already said they're going to say infertility, they're going to, maybe we didn't say that, but we knew that, but they're going to say long-term effects, right? And when they say long-term effects, by definition, they're saying, I don't want it for 5 to 10 years. I want to wait for 5 to 10 years of data. That sounds theoretically like sensible, like I want good data, but no, you're facing COVID right now.
But then what? That's exactly what I'm saying. Like,
right.
Okay, if we're all still here in 5 to 10 years.
Right, you're facing the disease while you're waiting to make that decision. And again, we're making risk-benefit decisions with a lot of uncertainty, not as much as before. And we do have some studies, and we're doing it all over the world, and we're getting data. It is happening, and it's looking really good.
I heard that.
It's looking really good. We really have to talk about that's very important is monoclonal antibodies, because one thing that we came further along in since we spoke in January is monoclonal antibodies. And listen, we're not here to push the vaccine. There may be people who listen to this and say, I'm not comfortable. I've even heard of these side effects. I don't want to take a risk. That's your choice, right? We're offering information. It's your choice. I do this all the time as a pediatrician. I offer information. I don't shove it down people's throats. I don't judge them. So monoclonal antibodies, even if you're not going to get the COVID vaccine, or even if you're pregnant and you did get it, you are still, they don't consider vaccination status. We know that you can have breakthroughs.
Right.
Even though we don't have data on that specifically in pregnant women. I don't know why you couldn't, especially for people who were vaccinated earlier. You can get monoclonal antibodies. It is more widely available. It is allowable. I don't know what the recommendations are in that though.
I think there's still not enough info. I think we wanted to bring it up last time, and there's still just not enough information right now. It's just not study. I'm looking at some studies right now, but they're not, we don't know.
Right, this is something to make the decision, with your healthcare professional. There's also the COVID Plasma Initiative people who have now pivoted to monoclonal antibodies. I'm sure they can be found online. I don't have the number in front of me.
ACOG says, here we go. Various monoclonal antibody treatments are available only under emergency use authorization. They are recommended for the treatment of outpatients with mild to moderate COVID-19 infection who are at high risk of clinical progression as defined by the EUA criteria. Pregnancy is included among the conditions that put individuals at high risk for clinical progression. This makes patients with pregnancy as their only risk factor eligible to receive outpatient monoclonal antibodies according to the EUA.
Yes, thank you. I'm looking for my COVID Plasma Initiative number, but I can't find it right now, but there is a way to reach them. And that is one way, or just ask your healthcare professional. But, I think we need to have a low threshold for that, particularly for women who haven't been vaccinated. And it has to be given early. It has to be given early if it's going to be given. Again, we don't have so much data to say, how effective it is. But again, we know that women who are pregnant are at high risk. And so we want to have that option out there.
Oh,
makes sense?
Another thing I wanted to mention, yes. During pregnancy, we have flu season coming back up. We also give out the whooping cough shot, the Tdap vaccine. So I just want to say from the ACOG website as well, there is no evidence that vaccination with either the influenza vaccine or Tdap vaccine increases a pregnant woman's or fetus's risk of infection with or complications from the virus that causes COVID-19. So we'll just have that out there. Those are the normal vaccines that we give during pregnancy.
Excellent.
They should still be given.
Perfect timing, as flu vaccine is out now for a lot of practices. I want to mention a couple more studies. One of them is preliminary findings of mRNA COVID-19 vaccine safety in pregnant persons. This is Tom T. Shimabukuro from the New England Journal of Medicine. This was April 21st, 2021. And this talks about looking at the VSafe registry. There's VSafe registry that had over 35,000 pregnant women enrolled, which is a ton. And there was a subcategory of the VSafe pregnancy registry, which is people, I guess, willing to do all that filling in surveys and online or whatever. Is a much smaller group of 3,958. And actually, I'm reading this, but this is actually, this is the same thing, sorry. This is the study where they talked about the 827 completed pregnancies. And unfortunately, there is a specific piece of misinformation about this New England Journal of Medicine study. Do you hear this one?
Go ahead.
You want me to do it?
You do it.
So the piece of misinformation that's being spread around is that 827, and they played games with the numbers. This was done in the first 3 months of this specific VSafe pregnancy registry, and they only looked at what happened within the first 3 months after vaccination. So the pregnancies that were completed in those first 3 months that were given early on were clearly early losses. That's what they were. So they calculate 82% were a miscarriage rate, which is not the correct denominator. The correct denominator would be all the women who were pregnant and vaccinated in that cohort.
Correct.
They didn't use that number though in their calculations. They used the 827, which is very confusing. So the people who quote that are kind of finding an error in this paper, to be fair.
Yeah. Yes.
To be fair.
It is wrong. It is wrong.
It was wrong. But still, it's not that they were trying to trick people and that there was some secret high miscarriage or early loss rate. There has not been. Not in the small group and not in the larger group of the VSafe registry. These are active databases where we're looking. So anybody who wants to can go to that study, and the preliminary conclusions where there are no obvious safety signals among pregnant persons who received mRNA COVID-19 vaccines. But of course, we need more long-term follow-up. This was just April. Very, very early. Like our talk was in January. This was the first 3 months in that time period. It's very preliminary, but it's very reassuring, and be very careful when you hear these studies being distorted like that. And again, if you ever have a question, hey, I read there's an 82% miscarriage rate from this New England Journal of Medicine study, go straight to Vaxopedia, VAXOPEDIA. That is a great resource. It's like the Wikipedia of vaccine misinformation. And you will find out, yes, you will find out exactly how that was distorted in a way probably better than I could explain. There's also a brand new hot off the press study, safety of the BNT162B2 mRNA, which is the Pfizer vaccine, in a nationwide setting with Noam Barda, BARDA et al. In the New England Journal of Medicine, August 25th, 2021. Today's the 31st, so it is super hot off the press. I'm very excited about this one. Plus it's from Israel, go Israel.
Yay.
And again, people can read it. I'm not really going deep dives into any of this. You've been very patient. I told you it'd be shorter, I lied. Sorry. I meant just to be shorter. I did mean it. So good.
There's too many things to cover. There's not enough.
I know. We thought it would just be a simple update, but yeah, I had 8 papers in front of me. So what the results were, looking
they're
at,
legit, right? They're legit papers.
I got a couple more. I just want to put these out there. I just want to throw them out there so people can look them up. People who are data wonks, they want to look them up, they can. What they were doing is they looked at these huge database from their population of healthcare facilities, and they had an average of 884,828 people in their vaccinated and control groups. So that is huge. And again, it's retrospective. We're looking backwards at databases, which is not a prospective controlled randomized blah, blah, blah. But what they saw that was interesting is that, and very important for people to know, is that while there are side effects of the vaccine, including that myocarditis, which I've discussed in other podcasts, exactly what that means. Please listen to Nothing is Risk-Free with Dr. Gregory Poland for a deeper dive into the myocarditis risk in greater detail. They found 2.7 events of myocarditis in vaccinated people per 100,000 100,000 people, but that compared to 11.0 events per 100,000 people in the unvaccinated people who had COVID. So they had a risk ratio of 18 something with myocarditis and COVID versus a risk ratio of 3. So about 6 times higher. That's been the calculation. And again, this is not set in stone. There can be errors in this calculation, but basically it's multifold higher to get myocarditis from the illness. So when you're saying I'm comparing the vaccine to the illness, which is the correct risk comparison, it is clearly higher to get myocarditis from the virus than from the vaccine. And basically they found tons of all of these other serious adverse effects from COVID, which is what we've been saying all along, and not nearly as much from the vaccine. So the vaccine, while not being risk-free, is much lower risk than COVID itself.
That's the best line. That is the best line.
Right?
Perfect. It's perfect.
Right? We've been saying that all along. But now we have actual data. Another study is, we didn't talk about breastfeeding women, which is a whole separate topic. I might leave that off. Other than I can tell you that my patients, my parents, my practice are often saving their breast milk to give to their older kids. They're so excited that they have antibodies once they've been vaccinated.
That.
What that does, whether it's broken down by the gut, whether it's not really useful, I don't know. I don't think we have good data, to be honest. However, it won't hurt. It won't hurt, and it might help.
Exactly. They were saying it's an IgA antibody as opposed to IgG, but I had mentioned in the previous one that I got the vaccine while I was breastfeeding. I couldn't get it while I was pregnant because the vaccine didn't come out yet.
Right.
But just to set the timeline there. But I got the vaccine while I was breastfeeding, and I just felt really great about it. But I think it's something that some women do feel more comfortable waiting to get the vaccine until they give birth. But we just don't know if those antibodies will go to the baby.
You mean the antibodies when you're vaccinated while pregnant? Because that's a separate question, and I did find something on that. I found 2 things. Because we talked about it the last time. We said, well, what if someone gets as pregnant and they get COVID while they're pregnant? Do they pass antibodies to their baby? And the answer is yes, they do. Yeah. Whether that's long lasting, it's a passive transfer. It doesn't mean your baby now has had the equivalent of COVID. Right. It's probably going to be lost in the first, 6 months or so. But that question has been answered by a study. That study was, let me find it, assessment of maternal and neonatal cord blood SARS-CoV-2 antibodies and placental transfer ratios from JAMA Pediatrics. Again, these are available online for free. Dustin D. Flannery et al. And this was from January 2021, so very, very early. And they did find, well, early in terms of the vaccine, it wasn't about vaccine, it was about COVID. And they did find that the maternal IgG does cross the placenta, and it's found in the cord blood. Again, not a reason to get COVID while you're pregnant at all. Yeah. There's not a question about the risk.
The risk is much higher
than the benefit.
The risk is just too high.
Right. But I want to be fair and give information and not I'm not trying to bang people on the head with vaccine. And I'm not saying, oh, well, look, there's a benefit, therefore you should get it. I'm just saying we had a question and that was answered. Right. And again, that's not permanent. People who think they're giving their baby their breast milk or getting COVID vaccine while they're pregnant, you're also not giving permanent immunity to your baby. That doesn't work like that.
It's just like the Tdap vaccine during pregnancy. It's because the baby can't get their Tdap until whenever they can get it.
Right.
So we're just trying to protect the baby for that period of time, in that newborn period.
Right. So then the question is, well, what about vaccinating? And here's a study, Coronavirus Disease 2019 Vaccine Response in Pregnant and Lactating Women, a cohort study. This was Catherine J. Gray and others from AJOG, March 2021. And this is a very tiny study because, again, the vaccine was
early,
just out there. And they looked at pregnant and breastfeeding and non-pregnant women in a very small but prospective cohort study. And they did find that there was transmission of the antibodies to the babies when the mother was vaccinated while pregnant. I don't think that it's going to be the same which part of the pregnancy you're vaccinated in.
Right.
I don't think that's a reason to say wait to the last trimester.
Right. Because pregnancy is high risk the whole time.
Right. Or you could
So-
get vaccinated before you're pregnant if you're able to,
Yes.
because it doesn't cause fertility problems.
Say what?
Louder for the people in the back. It doesn't cause fertility problems. And I have,
But it doesn't mutate your DNA.
and it does not enter your DNA. We went over that whole Snapchat thing. People should listen to our first talk. We're not repeating it, except when we really have to. So here's another one.
Actually, mostly new information. This is good.
Right. Well, that was the point.
Very good.
That was, yeah, well, thank you to Dr. Alyssa Hellman-Marciano, who came in the pinch because this is kind of last minute and sent me all these articles.
I love her.
Yeah, she's amazing. So this is an interesting study. This is Pregnancy and Birth Outcomes After SARS-CoV-2 Vaccination in Pregnancy by Regan, R-E-G-A-N, T-H-E-I-L-E-R, Thieler. Again, a free article from PubMed. I found this on PubMed. And it says they had 2002 patients, tiny again, relatively speaking. When I say 2002, 140 got the COVID vaccine while pregnant, 212 got COVID. So 140 got the vaccine, 212 of that cohort actually got COVID both while pregnant. And they found, unsurprisingly, that the vaccinated pregnant women in this birth cohort were not as likely to get COVID while pregnant, which is what you expect. But it's nice to hear that it worked for them in this tiny little study. But it's nice, you know, it's a nice little.
That's what we want.
Yep. And again, we have to understand that this is still very new. We're only like 8 months out. And that's it on my study pile.
Yay.
Finished my study pile. We talked a little bit about the breastfeeding. Anything else that we should talk about for now?
No, not. I think we're good. Definitely, it does not cause infertility. As OBGYNs, we do not want people to be infertile, you know.
Put you out of business. Well, except for the fertility docs.
Except for the fertility docs, but there's more regular OBGYNs.
Right, right.
So we like our jobs. We want to keep doing them. We want to, you know, bring your babies into the world. Like, this is what we live for. So we do not want people to be infertile.
Actually, the opposite is true for the fertility doctors. They would also, even more so.
They have been recommending getting the vaccine.
Right, but their motivation, Chas v'shalom, is not to have more patients coming to them because they're infertile. Their mission is to help people have babies.
Their job is to get people pregnant. So,
right.
You know, they're not looking for anyone to not be able to get pregnant. They want people to have all of the babies. We want to see those babies, and we want everyone to be healthy.
Men, yes, we do. So thank you so much, especially last minute, and especially for the third time, counting that addendum.
It's important.
So important.
Get this information out there.
So important. Thank you so much, and Shana Tova.
You too, Shana Tova.
Be well.